Welcome back, everyone, to this wonderful summit, and welcome back from the break. Hope you had some nice refreshments. I'm Alberto, a humble member of the Scientific Advisory Committee of our wonderful foundation, welcoming you from Wurundjeri Woiwurrung country. I have the great honour of introducing our next speaker, Professor Sharon Goldfeld. Professor Goldfeld is a pediatrician, public health physician, theme director, population health, and co-group leader of policy and equity at the Murdoch Children's Research Institute, and director of the Centre for Community Child Health at the Royal Children's Hospital, Melbourne. Sharon has built a career as a policy-focused public health and pediatric practitioner and researcher. Her research interests are made up of complementary, synergistic, and cross-disciplinary streams of work focused on investigating, testing, and translating sustainable policy-relevant solutions that eliminate inequities for Australia's children. During the 2020 second COVID-19 wave in Victoria, she was sought out to analyse the school transmission data for the Victorian Department of Health and Human Services. This report led to children being able to return to school, probably the single most important intervention for children. Sharon was recently awarded the inaugural Miles Medal for excellent and original research that led to outstanding achievement in research impact. So please join me in warmly welcoming Professor Sharon Goldfeld.
Thank you so much, Alberto. And let me just start by acknowledging the traditional owners of the land on which I'm standing, which is the Bunurong people of the Kulin Nation, and to pay my respects to elders past, present, and emerging, and of course, any First Nations people here with us today, and note that this land has never been ceded. I'm going to do the normal bit of hurry-kiri that we do when we do presentations and share the screen. I did try it before and it all looked good, so I'm assuming it all looks good again, and somebody will send me something if it's not. So I wanted to spend the next 20 minutes just talking to you about the indirect effects of COVID on children, and in particular, look at this idea of what might be the best road to recovery, taking into account both health and education. I sort of used this slide. I really like it. It was at a time when kids were writing things and there was a whole lot of chalk, and then there was all these beautiful pictures of rainbows and beautiful kind of flowers, etc. And then there was this one that just said coronavirus sucks. And I guess anybody in New South Wales or Victoria would probably agree wholeheartedly with that. But I also want to just talk about, particularly for this audience, some of the really interesting tensions we've had, and I'm a practitioner as well. So the importance of the N of 1, and I think when we're talking about children, for me, that's a really important touchstone. I'm still a paediatrician, I still see kids. And so the N of 1 is really, really important. And we've seen some really disturbing things as practitioners in what's happening for kids at the moment, things that have made us realise about, number one, the impact of the pandemic, but number two, the importance of the things that we took for granted, like kids going to school every day. But the other challenge that we have is how do we keep populations of children healthy and developing well? And what I'd like to spend the next little bit of time is talking about this idea of what are the things we could or should be doing to, number one, understand how children are doing as a population, and then number two, think about what we might do about it. So let's start a little bit pre-pandemic. As you heard in the intro, I'm sort of really committed to thinking about child health inequity, which I think will actually be the way the pandemic will play out, which is increasing inequalities for children. Now, it won't surprise you to know that pre-pandemic, it was not sort of equality nirvana, and that in fact, we had really substantial inequalities before the pandemic. So for example, this is looking at the Australian Early Development Census, which looks at child development along the whole country. It's measuring children's development in their first year of school. And what you can see at the bottom there, that 2009, 12 and 15, lowest and highest SES areas, really substantial, 10 years almost of just substantial inequalities. So these are really difficult things to address. And in a country like ours should be really disturbing, and the hypothesis is these are going to get worse. Then have a look at, these are looking at Naplan results, but particularly this is the Grattan Institute, analysis looking at the impact of parental education on children's Naplan results. And you can see from year 3 to year 9 that if you have parents who have higher degrees, you essentially, so a degree or higher, I should say, not higher degrees, that you can see the splaying of the results. Even those who had a diploma was still better than those who had no diploma. And these splaying, we call this the Matthews effect, along the lines of the rich get richer, the poor get poorer. The hypothesis is, and I'll talk about this a little bit later, that the sorts of things that are happening for kids at home will exaggerate these, because you can imagine kids have been at home now with all their degree or higher parents for quite some time, particularly in Victoria. And for those families who potentially have lower education levels, etc., lower access to technology, the sorts of things they're being exposed to. And then finally, around mental health, you'll recognise this is the survey of mental health and wellbeing back in 2015. And just a reminder, this is looking at the mental health of children in parents who are both employed and parents who are not employed. And you can see sole parent or carer not in employment right down the bottom there at 29.6. These are children with an identifiable mental health problem, remember, and we've got 30% in sole parent or unemployed families, sole parent unemployed, I should say, families. And even if you look at the highest and lowest income right at the top there, you'll see again that in fact there's twice the difference. So this is all pre-pandemic. So pre-pandemic, we had really substantial inequalities. Then along comes the pandemic. And I really like this because it just reminds us of these waves of impact for children and adolescents. And might I say, somewhat maybe controversially or not, that I think children have been to date collateral damage for the pandemic. And now is the time for us to really say, what do we need to do for children? We took them away from school because we were worried about them spreading and transmitting COVID for the adults. Now that we're vaccinating the adults, what are we going to do to make sure that we really have these kids not just recover and get back to, wow, isn't that great? We've got 2019 inequalities, but actually address that equity gap. And this is kind of cool because it talks about this second wave of COVID related to the restrictions that we're still seeing now. Like, we thought this was second wave way back when. We're still seeing it now with the impact of school closures, etc., and the impact on violence and child protection with children in homes that aren't necessarily ideal. Then this third wave of people putting off necessarily seeing doctors, healthcare workers, etc., and the disconnection from social services. And the fourth wave, which you can see started quite early, which is the idea of what is the kind of psychological and economic impact that we're going to see on families. There's a fair bit that's been written about this, and I could share a whole series of peer-reviewed papers on this, but we've done a fair bit of work looking at the factors that seem to be impacting on COVID-19. These are the indirect impacts, I should say. This is not the direct impact of the virus itself. We could have an even further, longer conversation about that, but suffice to say, in general, children are being spared severe effects of COVID, which I think makes us all feel pretty happy about that, but we should start getting concerned about these indirect effects. So there's these child level factors which related to mental health, child health and development, and poorer academic achievement, which is exactly what you would expect. Then these family level factors that also impact on children, which is around poor parent mental health, and I'll show you some data on this, reduced family income and job losses, household stress, increased abuse and neglect, which we are definitely seeing, and poorer maternal and newborn health. And then finally, these service level factors. We're sort of calling them community or service level factors. So the school closures, reduced access to healthcare, and increased use of technology. So this kind of distancing between the children and the family and the direct service provider. And of course, all of this disproportionately impacting on children experiencing adversity. So I want to share with you just a little bit of data and then move to sort of what sort of things we might do. So at the Melbourne Children's Campus, you can see down the bottom there, we have something called Life Course. So what we did was kind of spun up all of our longitudinal studies to say actually what's happening to these kids during COVID, because of course, with this, we get a chance to say what were these kids like beforehand, what are the risk and protective factors, and then what's happening during COVID. So 3 studies I'm going to particularly talk about, which is Right at Home, the Maternal Health Study, and the Australian Temperament Study. So just very quickly, and I'm going to run through these, and I'm welcome to share these slides later. So you can see all the authors down the bottom of these fantastic studies. But maternal health study, 1 in 5 adolescents, and this is a general community study, recorded frequent suicidal or self-harm ideation. And we know from emergency presentations that self-harm has gone up. And we all know that suicide has not, and hopefully will stay not, but self-harm has gone up. Then in a families already experiencing social adversity, 1 in 4 of them reported job or income loss, remembering that already for this study, I can tell you that 1 in 2 already didn't have a job. So this is a further 1 in 4, and nearly 1 in 2 had significant family stress, and most of that was interestingly related to remote learning. Another study, again, an intergenerational study, 1 in 3 parents with young children reported experiencing some form of financial difficulty. And we think the parents with young children are particularly experiencing this. And then finally, the hardest hit were those already experiencing adversity. And we're really seeing this. We're seeing this around the world, I can say, that those who are hardest hit are those who are already experiencing adversity. So 23% of families who are disadvantaged pre-pandemic perceive their financial situation as just getting by or worse. And just remember, this is already with the other financial policies that were put in place, such as the increasing of JobKeeper and JobSeeker, with some hints at some great protective factors there, such as if you already had social support pre-pandemic, you were doing well. And a number of parents reporting in a number of these studies actually that they really enjoyed the time with their family. So I think there'll be some resilience factors in there. The Royal Children's Hospital National Child Health Poll has been going pre-pandemic, but it just happened to capitalise on this national natural experiment. So you can see the national lockdown was 30th of March to 12th of May. The National Child Health Poll came out in June, in which case nobody was in lockdown. And then we did it again in Victoria, for everybody, in September. And then we started to see these real differences between Victoria and the rest of the country. And then we were actually able to have a look at it in July of this year. And we're able to look at the mental health findings that whole time. So some really interesting findings. So in June 2020, after the first lockdown, already 1 in 4 families were reporting job or income loss, and 1 in 3 reported material deprivation. This is remembering already with some alleviation with the policies in place. In September, when only Victorians were in lockdown, the negative impact of the pandemic on mental health increased by 14% for caregivers and 12% for children. And heads up, not that you really were surprised by that, much worse in Victoria. Now in July 2020, July 2021, that should be, not July 2020, almost 60% of Australian parents reported a negative impact on their mental health. So this is when New South Wales and Victoria were both in lockdown, and a third also reported negative mental health impacts for their children. And not surprisingly, parents who are less well off reported worse mental health. But perhaps for me, this was a really interesting study that was done by the Victorian Commissioner for Children and Young People. And it was a quote from one of the young people. They had a kind of sample of about 300 kids that they did both in 20 and 2021. And that person said, "I feel like I'm on fire while people with hoses are standing and just watching. That's the best way to describe how I feel since COVID started." And I think this goes to the way children and young people feel around COVID, that they've kind of been left and not really looked after. So let's just talk quickly about school closures. And you'll realise, of course, that school closures have been massive around the world. This is just an extraordinary thing to show that in April 2020, school closures affected 86% of children in the world. That's 1.4 billion children. And of course, in Australia, we were locked down as well. And just to give you a sense of that, this is what it looked like in terms of schools that were partially open or closed. And you can see that essentially over the entire world in April 2020, no schools were open. It's actually kind of mind-blowing, really, when you think about it. There's been further, this is all UNESCO data, but it's really interesting to look at. These are the total duration of school closures around the world. You can see Australia sits there at 31 to 40 weeks. Other countries have got a little bit longer than that, depending what one means with a true school closure. But you can get a sense that around the world, many countries have had really substantial school closures, and in the global community in particular, that's had massive effects on children, in particular in regard to, for example, child marriages, child nutrition, etc. And just to give you a sense of good old Melbourne, I know everybody is here from around Australia, but just to give you a sense of the amount of weeks the Victorian children have missed out on, anything that's red or brown is a school closure. The brown means also childcare was closed, and the blue is partial closure. So there was only schooling for foundation to grade 2. So it doesn't really take much to note how many weeks of schooling kids have actually missed. In fact, they'll be up to now about 34, 35 weeks. If it gives you a sense of this, the entire school year is 40 weeks. So what do we know about the potential impacts of school closures? Well, what's really fascinating about this is that we're looking at proposed impacts, and the actual data on school impact is really just starting to emerge, and you'll recognise that a lot of it's emerging from the Northern Hemisphere. But these are the potential effects that we're interested in. For example, the physical effects of children being less active, having longer screen time, eating less healthy diets, and loss of access to the sort of public health interventions, like some kids still go to school for breakfast, and this is true in Australia as well. And then, of course, the mental health effects associated with COVID itself, but frustration, lack of motivation, lack of in contact, etc. And you know, I think at these moments, it's really important to cast our mind to the sorts of various homes that children are living in. Not everyone gets to live in a big home. A number of them are very small apartments, etc. And so there really is some real challenges for families thinking about trying to homeschool, thinking about how parents can look after themselves, and of course, the actual support that children need in homeschooling. And it won't be surprising to you that vulnerable populations in particular are likely to lose this, what we're calling a delay in cognitive gain. So people have sort of talked about learning loss, but actually the real concerns people have is a delay in cognitive gain. In other words, children are unlikely to lose what they already knew, but actually not gaining where they should be. And of course, we're very worried about the early years where there's quite rapid gain that's needed, and children for whom really they just didn't have access to the sorts of things that were needed, such as the sorts of phones, the sorts of tablets, computers, etc., that are needed, as well as having access to data. And just in your minds, you can imagine that. What's interesting is also to look at long-term school closures and ask ourselves what might be the impact of long-term school closures. This was a paper that came out through Russell Viner back in 2020 saying, not sure that's even it being quantified, but it turns out that the OECD did try and quantify this. They put out a paper that was called The Economic Impacts of Learning Losses. I put in there the Australia data, so just to orient you to this data, which is kind of interesting. What you've got in the left-hand column is our current GDP. It's the 2019 GDP in billions of US dollars. And then on the right-hand side is the losses scaled out to 80 years. So by the end of the century, what sort of losses will we see? And you can see that this is also billions of USD. But just to give you a sense, so 2/3 of the year learning, so that's what we're seeing here in Victoria, the 1716 is billions USD, and you can see that's almost the same as our entire GDP at the moment. This is 80 years out. The moral of the story is all of this is modelling. We don't really know, but people are very worried that the learning loss at scale will be substantial. I wanted to share with you some things that have come out from the Northern Hemisphere that are very useful for those of you who are interested now in what I would like to put forward as schools as being integrated recovery platforms for children. And I would like to suggest they are the integrated recovery platform for children, taking into account and understanding the importance of all the other services out there, including the mental health services, that actually schools are where children go. They go 5 days a week, 7 hours a day, 40 weeks a year, more or less, in some shape or form. And that as a mental health care system, we might be able to do other things on the outside of that, but schools really represent the most important recovery opportunity. So 3 very nice documents. One is what they call a result from a policy bench in Canada, but looking at the effects of school closures and in particular what might be the mitigation strategies, which I'll share with you in a moment. And then the same thing from UCL in London, looking at the mitigation of the effects on primary school children and also on parents and carers, noting what it's been like during school closures. I do have to say, and all 3 of these documents reiterate this, that the evidence around this is emerging. For many countries around the world, they didn't do their standard testing, so some of that isn't around. Australia did do their standard testing, and of course, you'll know the Naplan results are out. They've shown that there hasn't been, on average, any differences. I would suggest that we're going to see massive inequalities actually as a result. And then finally, my last, I think Bruce is coming on to tell me I better hurry up. My last 2 slides. One is from the Medical Journal of Australia. This is a paper we did looking at what could the future look like going forward. And what I'd like to suggest is that schools could really be integrated recovery platforms. These are the sorts of things they could do. But in the bottom right there, you're looking at these tiered supports. And I would like to suggest that schools could really be holistic mental health and learning platforms. And in fact, in that paper, we talk about this idea, instead of having Naplan, that we would have the National Assessment for Health, Wellbeing and Learning. And wouldn't it be interesting if we could truly disrupt the way schools operate at the moment and make them real integrated recovery platforms for children? So I leave you with this one quote. It's from Susanna Arundhati Roy, who wrote The God of Small Things, for those of you who have read it. And she says, historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our databanks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly with little luggage, ready to imagine another world and ready to fight for it. Thank you.
Thank you, Sharon.
That was pretty good. Only 2 minutes over.
It was a great contribution. Again, tackling this issue of inequality and focusing it through a child and family focused lens, which is absolutely vital. But ending on a positive note, which is an absolutely brilliant lateral idea, that is, schools are the integrated recovery platform, not just for children, but for families, which was a nice segue from something Matt Sanders was saying earlier. Thank you so much for your contribution, and not just today, but of course, in our community and generally, particularly at this time. Thank goodness we've got people like you driving science, evidence, and humanity well. Thanks again. We're going to move now from Professor Goldfield to another wonderful contributor, this time from, if you like, across the ditch, which is great. We've got so much to learn from New Zealand in all sorts of ways, and I certainly acknowledge that. You get it right so often. And I'm now introducing Associate Professor Caroline Bell, who is at the Department of Psychological Medicine, University of Otago, very distinguished department, which has had a big impact, not just on Australasian psychiatry and psychology, but internationally. Welcome, Caroline. You've done so much research on post-traumatic stress, studying it longitudinally in the real world in relation to disasters in New Zealand, such as earthquakes and so forth. And you're now going to address us on this ongoing vital topic of the world, both during the pandemic and post-pandemic recovery. Welcome.
Thank you. Lovely to be here. I'm just going to share my screen. Thanks so much, Bruce, for that introduction and coming in and hearing Sharon's talk and that most wonderful quote at the end. I so enjoyed that. So what I'm going to talk to now is slightly different. Rather than having a direct focus on the COVID pandemic, but talking about what we've learned from disasters in New Zealand over the last decade in the context of the Christchurch earthquakes and then the tragic mosque shootings 2 years ago. And I hope that can inform our thinking about the pandemic context as well. So I've divided this presentation into 3 broad realms, which of course overlap, but I'm talking first about what happened in those 2 disasters particularly, then what we saw and are seeing, and then trying to pull it together into what we've learnt and how that can inform our thinking going forward in the context of many other disasters. So this is the Canterbury earthquake when it struck a decade ago now, and literally when the city fell. Some very dramatic pictures, but obviously it had a huge impact on the city. 185 people died, there were multiple injuries, and the infrastructure was destroyed for a long period of time. So this is just some pictures depicting some of that destruction. And if I draw your attention up here, this black oozing stuff, which is called liquefaction, not a word that I had in my vocabulary before, but certainly now do. And it's almost the thing of nightmares, actually, this black, foul-smelling, oozing mud that came up repeatedly with aftershocks as well. So all this destruction, but at the same time, in the top right picture, this is students who got themselves into groups of 10 immediately after the earthquakes and went round digging people's property out over the city. So in the midst of all this horror, this remarkable pulling together and people being so human and so engaged and wanting to help each other. This is a picture of aftershocks that were experienced. So the bottom frame is the total number, but perhaps if we look at the second frame down, and you can see that over the course of a week, there's about 14 aftershocks that happen, and each one of those feels just like an earthquake is starting. So you're kind of getting yourself ready and then it doesn't actually progress, but you're in this heightened state of alertness repeatedly. And I often joke that I don't think there's any ethics committee in the world that would allow you to put rats through this kind of experiment over a 2-year period, being exposed to over 10,000 aftershocks, which the city was. And then there are the secondary stressors. So Sharon was talking about those as well, but the things that unfold after the disaster starts, and they usually hit people on every front. In each disaster, they're a bit different. So in the earthquakes, there were big battles with homes and insurance, delays in rebuild, and financial implications, families being massively disrupted, children moving into parents' beds because they were so frightened, family moving away, sometimes worse, family moving in. So lots of challenges for people, workplaces being relocated. And a lot of people talked about the whole landscape of the city was changed. You couldn't find your way around. There were no familiar points. And that was very both disorientating, but also this continual exposure to the destruction that had happened. Okay, so turning now to the mosque attacks. These happened on the 15th of March, 2019. And this was one supremacist terrorist who attacked 2 mosques. He drove between them during Friday prayers. and live streamed the attacks on Facebook. So that was widely viewed across the city, across the country, and across the world. And there were layers of impact. So 51 people died, the shuhada. 49 people were injured. There were approximately 300 people in the two mosques who witnessed truly horrific scenes. There were the families of those present at the mosques, terrified, trying to find out what had happened to their loved ones. There was the wider Christchurch community. So the Christchurch Muslim community is about 4,000 people. Many, many people lost very dear friends and have been providing ongoing support. There were, of course, the emergency personnel who responded, but also neighbours, taxi drivers who drove people to the hospital. And there was only one hospital in Christchurch. It's a tertiary centre. It took everyone at the same time. And then there were impacts both on the wider Christchurch community. I mean, usually we think nothing happens in Christchurch, and now we've had earthquakes, we've had the mosque attacks, people couldn't really believe it. But there's also the impact on the wider Muslim community spread throughout New Zealand. It was a devastating impact on them and a very terrifying experience. And it's important to remember in the context of this attack that this was on the background of many people feeling that there was a pre-existing sense of discrimination and a failure of authorities to address that. Many people, certainly not all, but many of the people had moved to New Zealand as migrants and had seen this as a safe haven. And that sense of the world view and that security was absolutely shattered. And it was a community targeted and vulnerable because of their faith, but at the same time, their faith has also provided protective elements for people, feeling that it wasn't their time, that the shuhada were martyrs and had died in the best possible place in a mosque at a time of prayer. Again, secondary stressors have unfolded, and these are different from after the earthquakes. So there's been a massive change in family dynamics because many of the people who died in the attacks were relatively young men who were the providers of the families. There have been huge financial and housing ramifications. Massive immigration issues with families wanting to come and support their loved ones in New Zealand, and that being very challenging even before COVID happened, when it's just so complicated now. And repeated court and coronial processes, which are still ongoing. The coronial processes, you may remember the terrorists pleaded guilty, but there was a sentencing in which many of the family members gave victim impact and statements face to face with the terrorist. Hugely difficult for people and hugely difficult to move on with these constant triggers. Okay, so turning now to what did we see? I've divided this into the acute reactions when you're in the context of a life-threatening event, such as the earthquakes or the mosque attacks. So there's intense fear immediately or usually both, distress happening at the same time. Reactions are very easily triggered by different things. So for the earthquakes, it will be the aftershocks or trucks going by, something that made the ground shake. In the context of the mosque attacks, it would be things that sounded like a shot. Lots of avoidance of places that reminded you of the event. So for example, the mosques, in the earthquakes, it will be the city centre or multi-storey buildings. And lots of anxiety about being separated from home and loved ones, and racial fears and cultural fears after the mosque attacks. Then reactions to the secondary stressors, although they're different causes, what people report in response to them are feelings of fatigue, bone-numbing exhaustion, poor concentration, difficulty with decisions. We called it earthquake brain, but it's equally being described as flood brain or bushfire brain. And I think in the pandemic, we'll probably be calling it pandemic brain as well. This feeling of loss of control, that everything feels uncertain, and how difficult that is for us. Anger being very close to the surface, and as I've talked about, things being very easily triggered. But not all, it hasn't all been negative after both the tragedies that we've experienced. And again, I think this rings true after the pandemic as well. Many people talk about reevaluating what's important in their life. And it is usually themes of being closer to their family and friends and that sense of community and pulling together. Learning about their own personal strength, what they have been able to deal with, and recognizing that in themselves. And often the importance of spiritual or connection with faith has been really important for people, and to lean on that. Okay, this is a summary slide that we found very helpful to talk through, particularly the community responses after a disaster. So it's very much a summary slide, but I think it is helpful if I just talk through this a little bit. So sometimes there is a pre-disaster warning period. So obviously this wasn't the case for either the earthquake or the mosque attacks, but sometimes, for example, a flood there is, or with the pandemic, what we were hearing around the rest of the world, knowing that this was likely to come. And then the event happens, and then this is followed by this honeymoon or heroic period. And I've touched on this a little bit with that picture of the student army, but the sense that you could ask anything of anyone, and it felt like more human than almost things ever were before. And then there's this downward trajectory where really how difficult everything is, how long it's going to take, really starts hitting in, and that's called the disillusionment phase. And that's followed by a gradual, very up and down recovery, with setbacks along the way that I've alluded to. And this line on the right-hand side is purposefully drawn a little higher than this pre-disaster line to talk about the concept of post-traumatic growth. And for some individuals, not all certainly, but some who've been through really stressful times, or communities that have been through that, talk about moving into a different phase where they do feel more connected, more recognizing their strengths in themselves and their community than they ever did before. Okay, another summary slide now, but I sometimes think pictures are better than words. This describes the potential disruptions in functioning after people have been exposed to really threatening events. So on this axis here, this is increasing difficulties with functioning. So not doing so well the higher up you are, and obviously time along the bottom. And most people follow the green or the blue lines. So there is certainly some difficulty initially, which can go on for some considerable period of time, but then people recover. It's up and down, but that is the trajectory, and that is the majority of people. Some people follow this red line with difficulties almost immediately, which continue. And then we've also saw this repeatedly. Some people who were not perfectly fine, but were kind of managing, and then something happens, which could often be relatively minor and a last straw event, and then they have significant difficulties. So a delayed onset of difficulties. So as I've alluded to, the majority of people exposed to disasters do not develop mental health problems, but some do. And those that do develop are these. So post-traumatic stress disorder, we often hear a lot about that, and that's absolutely the case. Also remembering that depression certainly occurs as well in significant numbers. Other anxiety presentations and somatic or physical health presentations as well, particularly after the mosque attacks, we saw that. Okay, turning now to what helps. And these are some of the principles that research over the years have shown helps communities have better outcomes. And this is the importance of a sense of safety. People need to feel as safe as they possibly can. Often that requires really clear, trusted giving of information. The importance of social connection. And again, Sharon talked about that as that being one of the protective factors, and that's repeatedly shown. The importance of people being connected to other people to have a more positive outcome. For people themselves and communities to be empowered to help themselves, to build on their strengths, and for it to be a bottom-up, not a top-down approach. For there to be a sense of calm and hope, and that again is leaning on the clear information giving. For things to be flexible and adaptive, that you need to do new things at new times, but also for things to be joined up. This is some of the wonderful messaging that was seen after the mosque attacks, and the response the country to that was truly amazing and extremely positive. This is a summary slide, again, talking about building on layers to provide support. So it depicts a lot of things, this triangle. Really, it's saying that most people require inputs in the lower layer. So this is both the majority of the population, but also the kinds of things that they need are the community supports that are trusted and already there and with their family, and involves things like psychoeducation, very clear messaging, supporting and building on that. The next layer up is, again, slightly less people than the lower one, but that requires more supports, such as practical supports, short-term psychological interventions. And then the top of the pyramid is, again, the smaller number of people, but those who might require more intensive psychological inputs. Okay, just some reflections now, and trying to pull, I think, some of the learnings that we've had into a cohesive picture. And again, I think some of this can inform our thinking about the pandemic. So what we found, and again is found around the world after disasters, in the acute context, there is this massive influx of help, and that is often needed. It's certainly well-meaning, but it's very difficult to manage, and it's almost like psychological services are parachuting in to help the community. And while that is helpful in the short term, the problem is people leave, and so are only able to stay, of course, because they're coming from abroad for a very short period of time, and that can be very disruptive. And actually supporting local services to provide that is really a better way to go. The social and practical stressors are massive for people, and it is their priority in the acute context to deal with those. People need to feel safe, they need homes, they need food, and their families need to be together. It's not psychological input that's usually required, it is dealing with those practical things. However, dealing with those practical things often involves multiple agencies. And that's a real struggle. Dealing with any government agency is already a challenge, but dealing with lots of them at the same time is really difficult for people. And a constant theme after disasters are reviewed is that people want a single point of contact for all these agencies. So for example, after the mosque attacks, these are all the agencies that were involved. And you can just imagine how confusing that is for people to navigate. In the longer term, I think we really need to remember how long the tail of all this is. It's often years, and that's difficult because people's and government's attention often is in the acute context, but the psychological issues can go on for a very long time. How difficult the triggers are, and I think I've alluded to that throughout this talk. The importance of trust. Now, this has been a real challenge in both the disasters, actually. People want to trust people, but they feel alienated by agencies, and that trust is very difficult to rebuild. I can't emphasize enough that dealing with the social and practical stressors is vitally important. We need to address those alongside any psychological issues that are being that come to the fore. And then the other thing is that people get exhausted. There are really vicarious impacts. So in the example of the mosque attacks, the local Muslim community have been doing wonderful work supporting their friends and families. But they've been doing that now for 2 years and they're exhausted. We saw that after the earthquakes, and I think we're going to see that after the pandemic. We're certainly hearing about it in the health service. Okay, so the final slide, really. I think one of the things I've learned is that a disaster is just the start of a really complex series of life events that then follows. I think before all this, I would see something happening on the television, a flood or something terrible, and then you think people have moved on, but this takes ages and people are hit on every front. It's really important to keep front of mind that the vast majority of people, despite all that, do not develop long-term mental health problems. And that's remarkable. I think that's really remarkable. But some do. And it's a long tail, and we need to be able to provide for that. And it's absolutely vital that we understand and connect with the cultural context and build that into our thinking from the ground up.
Thank you, Professor Bell. It's a lovely word to finish on, stronger together. And you've demonstrated something really very profound, and that is we can learn from other experiences in life. And you've brought profound learning on people's reaction to disaster, which gives us a model to apply, for example, to the difficulties and stresses of the COVID challenge. But more than that, you've given us some hope and some ways forward with a nice list of ways in which communities can change for the better, a second order change, a new door opening, as we've heard from a previous speaker. We do appreciate your input and thank you for joining us from across the Tasman. And we hope, and to all our friends and colleagues in New Zealand, that you all go well and remain vaccinated.
Thank you.
All the best. I move now to our next speaker, who's a great friend and colleague of mine, Professor Brett McDermott. Now, Brett is a leading child and adolescent psychiatrist, not just as an academic, but also as a clinician and as the developer of policy and child and adolescent mental health services. He's currently really in two places. He has a chair in child and adolescent psychiatry at James Cook University in far north Queensland. And as well as that, he's leading amazing second order changes in child and adolescent mental health services in Tasmania. Brett has a distinguished career, including, for example, being a director of Beyond Blue and being a member of the federal government mental health expert reference group. I welcome you, Brett, and look forward to your address.
Thanks very much, Bruce. Can you hear me okay?
Yes, we can.
Excellent. I shall screen share, hopefully. And so hopefully you'll see more than me, which is... Okay, that looks promising. Can you see a presentation? Oops. Can you see a presentation, Bruce?
Yes.
Oh, good. Okay. Well, thanks very much for the opportunity to have a chat. And you know, wonderful talk by Carolyn, and I got some of Sharon's as well. So in some respects, my kind of work's done, but I'll try to bring out some sort of you know, different perspectives. I was going to say a little bit about you know, what I've been doing in, which is now 25 years of disaster research, but kind of have a focus mainly on community, and also mainly on how it affects practitioners. And we might segue to the mental health of the workforce prior to COVID and prior to disasters. So I'm going to talk a little bit about single event traumas, which are natural disasters. They're generally kind of single event. But then I'm going to finish with, well, what about the more complex disasters like adverse childhood experiences, like you know, sexual abuse and physical abuse and neglect? And do they actually talk at all about you know, the pandemic? So we'll go through this obviously fairly quickly. Just the credibility slide. I was kind of surprised to see that I was involved in service provision after a bushfire in 1994, and Carolyn, the danger is that once you you know, have an interest in this area, 25 years later you're still doing it. But I've been very privileged to been able to offer some assistance, I hope, to people after bushfires and cyclones and floods, mainly with my my research bestie, Vanessa Cobham, the wonderful Vanessa, who's associate professor in Brisbane. I'm not going to show you many stats, but early on, we had these kind of fairly simple ideas that things like, you know, PTSD were predictable. And this is a publication way back in 2002. And you can see that if you thought you were going to die during this event, and this was a bushfire event, you had an 8 times chance, an 8 times the likelihood of PTSD, independent of age and gender. And I have a very strong suspicion this is the same in the pandemic. If you're in intensive care, if you're about to be intubated, if you think, you know, you're going to die or think you won't wake up, I suspect that will be very highly predictive of PTSD. We moved on in kind of sophistication and started playing around with these more kind of structural equation models. And I think the interesting thing for this particular talk, and my little theme is on community, is very quickly we looked at social connectedness. So this is about 800 kids. It's after Cyclone Larry. We're predicting child PTSD. And this model actually predicts 60% of the variance of PTSD, which for mental health is actually very high. We've put in exposure to the cyclone because we thought that was important, obviously. Everyone does. We've put in threat perception and social connectedness. And really interestingly, there was no direct link between being exposed to this very frightening event. It was all mediated by how you perceive the event, your threat perception, which was also influenced by how socially connected you are. And young kids, these are actually age 3 to 12, grade 3 to 12. So this is right across the school range. If you are connected to your peers, you were very protected from PTSD. And if you were socially isolated, you had 4 times the chance of PTSD. Now, being a child and adolescent psychiatrist, you move, and Carolyn pointed this out very nicely, that after the acute event, obviously people get PTSD, and there's like a threat perception pathway. You get PTSD or anxiety. But don't forget, in disasters, you can have lots of loss. You can lose, obviously, loved ones, but you can also lose pets, which for kids are incredibly important, or possessions. So you can have a loss, grief and depression pathway. And in fact, a lot of the kids after natural disasters, there's actually relatively more depression than PTSD. A chronic event, and this is where we're getting into like the pandemic. The pandemic's a chronic disaster. And, I think that 8 Melbourne lockdowns, which you have my great sympathy for, folks in Melbourne, is a little bit like kind of 8 aftershocks, really. A chronic event, you're much more likely to get depression, but also some of those other things that you don't find in a diagnostic nosology, things like relationship breakdown, increases in domestic violence, increases of substance abuse, and breaking down of those kind of family structures. Now, I'm not going to talk about this wonderful slide because Carolyn did it beautifully for me, but I'm just going to say that from the pandemic's point of view, I think we're looking at this very long tail, and they might have been exactly the words Carolyn used, but the longer you are in disaster planning and research and project delivery, the longer this goes on for. And when people say they are still troubled 3 years later, I'm completely unsurprised. Recovery takes a long, long time. And my blue line suggests that this is the kind of recovery that's a bit quicker than the red line. This is where you put in economic packages to help people get back on their feet quickly, when you look after people, when communities actually are very cohesive and work together. The red line is where there's persistent, profound economic issues. Now, we have a glimpse of this after the global financial crisis, and in Spain, the global financial crisis was actually called the Great Recession. It hit some countries profoundly worse than Australia and New Zealand. They found suicide, 3 years later, 2 and 3 years later, it was really kind of picking up rather than in that first year. So I think recovery is long, and it often depends, how much we economically support each other as well as emotionally. Being a child psychiatrist, obviously, when I think of community, I think of parents. When I think wider than the individual, I think of parents. And we've got a lot of data that shows there is parenting change. I won't dwell on this. Anyone can contact me if they're interested, but parents are much more likely to take autonomy away from their children and be hypervigilant and overprotective. And in fact, this is mediated by parents who themselves have PTSD cognitions. So the bottom part of this slide is, if a parent had PTSD cognitions, then they were 9 times more likely to fundamentally change their parenting and again be hypervigilant as parents and be overprotective as parents. This is really important because I think in the wider community, we're going to see interesting behavioural change amongst individuals depending on how exposed they were. Okay, little segue into the healthcare professionals. And this is the Beyond Blue study of 11,000 doctors and medical students in 2013. I just want to remind people that there are some sections of society from a professional point of view who pre-pandemic were doing pretty badly from a well-being point of view. So you can see here, and I've just drawn some blue, kind of the bottom of the confidence intervals. You can see that male doctors in terms of psychological distress were higher than the general population and other professionals, and female doctors were higher than male doctors, but higher than other professionals and the rest of the Australian population. And the medical profession pre-COVID, and I'm saying this a lot, pre-COVID had spectacular results. I mean, if you told a mother of a medical student that their loved one was going into a profession that in the 18 to 30-year-old practitioners, 47% of them would feel emotional exhaustion at some stage, and 45 of them would be cynical. The slide I haven't put in is in the 12 months prior to doing this survey, 25% of Australian doctors said they'd felt suicidal. You know, COVID is not going to make this better. And I think that I have really kind of profound concerns about our health profession. Now, that means I don't have profound concerns about other people like hospitality, but there are professions who are going to struggle after this pandemic. And by the way, all these things are interrelated. We published a study from some Chinese colleagues just 6 months before COVID, which shows, you know, that compassion, satisfaction, feelings of burnout, secondary traumatic stress, depression, anxiety are all incredibly interrelated from a workforce point of view. Well, what's long-term effects from COVID? We don't know yet, but there's a lot of emerging data that someone will put together soon. And I think it's going to be dependent on what your reality was from a professional point of view during COVID, obviously. Now, my last little kind of aside is, well, that's all very well and good. And I think single event traumas can tell us a lot about the pandemic. But are there other kind of heuristics which are useful? I've always been incredibly interested in the work on adverse childhood experiences, which of course came out of an endocrinologist interested in trying to explain treatment-resistant morbid obesity, in fact. And a lot of patients were saying things like they had histories of sexual abuse and physical abuse and emotional abuse. And most studies have this kind of 9 adverse childhood experiences. Now, why is it important? Because it's highly predictive. So there is a dose response of the ACEs you experienced as a child and adult depression. And you can see here Chapman's work that if you have 5 ACEs, if you have 5 ACEs, you are 5 times more likely as an adult to get depressed. If you have 4 ACEs, 16% of people with 4 ACEs actually have alcoholism by self-report, and 35% drug and alcohol abuse. So these are very profound relationships. We'll just go to the bottom one, Kudajar, 2010, a self-report history of sexual abuse before the age of 16. And you can see that these are non-specific risk factors for a whole range of mental health problems. So if you self-reported sexual abuse, you are twice the chance of a psychotic disorder, which people don't really understand and know very much. Twice the chance of affective disorder, but look down the bottom, 6 times the chance of borderline personality disorder or drug abuse or alcohol abuse. So these are non-specific risk factors. Now, why am I going on about this? Well, this is why I'm going on about this. Some people clinically come up to me and they say, well, you know, she's taken a profound drug overdose and what seems to be a serious suicidal attempt, but it was really a fairly trivial stressor. You know, her and the boyfriend had an issue and, you know, took, in fact, you know, 30 grams of paracetamol. Similarly, you know, a boy, you know, attempted hanging after what seemed to be a fairly trivial argument with a couple of friends. What I think the issue here is that some people are chronically sub-threshold. So I think there are some people in society who have huge numbers of adverse childhood experiences, and it doesn't take a very large youth stressor to get them to this suicide threshold. And increasingly, we know what this is mediated through. We know that if you have large numbers of adverse childhood experiences, there are now many, many papers showing epigenetic change. So you have an epigenetic mark and your transcription speed is generally lowered, although in some areas it's increased through a methylation or another process. We know that these people have HPA axis dysregulation, and we've just published a couple of reviews on hair and nail cortisol that kind of predict this. Akemi Tamada in Japan has been publishing these amazing papers about structural brain damage after sexual and physical abuse. This is mediated through attachment and dysregulation. Now, I'd just like to say that in my view, and the youth that I've been talking to from a clinical perspective, are really describing COVID and climate change in very similar ways that they describe other ACEs. And I think in the last 5 years, we've kind of added 2 more ACEs that I think will be highly predictive. Young people are, feel very strongly their future has been, in some cases, permanently changed by the pandemic and the change in opportunity. And we know that many, many youth are incredibly distressed by what's happening to the planet, and also what people my age are not doing to stop that happening to the planet. So I think that these things are worth considering in terms of the adverse child event heuristic. So to summarize, I think very much agree with what Carolyn said, that in terms of single event trauma and natural disasters, we can extrapolate that to the pandemic in terms of what sort of mental health presentations get. We can, from both a research and an experiential point of view, connectedness is incredibly important. And, the fact that some people have found connectivity during the pandemic online has been fantastic. We know the natural history is much, much longer. Whatever you think about the natural history, it's kind of like double it, and you'll be much closer to what it probably is. And there are differential burdens. And I heard at the end of Sharon's presentation, she just reminded us that the lived experience, just the housing of people is fundamentally different. I mean, how a single mother with a couple of boys with ADHD and an understandably depressed teenagers got through this time, I just don't know. And I think on top of that, I have these added concerns that we might have invented 2 new ACEs which are highly predicted. Just to end on a positive note, I've been involved with a group of mainly young doctors, although some of the people will be pleased to hear me call them young, but a group of mainly young doctors has started something called hand-in-hand peer support. Please Google it, have a look at it. Basically, we offer training in how to be a peer support facilitator, and we offer peer support to anyone in the healthcare profession. And that's been proven by many people to be very helpful. Thank you, Bruce. That's enough from me.
Indeed, thank you, Professor McDermott. Brett, a tour de force, very wide-ranging, but it's raised a couple of issues of relevance to this Mental Health Month series of seminars. Firstly, you'd be interested to know, and you may have even seen it, that several days ago, our seminar was on health services workforce, mental health, and we had some very moving presentations in that, which you further underlined about the risks that the medical profession and health services are under currently, which builds on pre-existing risks. So thank you for raising that. The other issue that you've introduced into the conversation, if I can use that catchphrase, is this notion that ACEs, adverse childhood experiences, might also be COVID and climate change. And so we have to watch that one, because rather than give up hope about all of that, it does offer some opportunities for early prevention and perhaps even early intervention with children who have experienced extraordinary and stressful experiences. We'll certainly be putting hand in hand peer support as a resource on our website at the Foundation. And it resonates with the fact that the Foundation runs a number of support groups for various sorts of conditions and groups. And we're sold on the evidence for that being a very important intervention and help for those either to prevent mental health difficulties or to help those that already do. It's now lunchtime, and you've deserved yours well and truly, Brett. We'll say cheerio, go well. We're glad everybody's getting vaccinated, and it's now lunch break. Enjoy some healthy food, because of course we know eating well is one way of promoting mental health. And we'll join again at 2:50 Eastern Summer Time on the dot, when Professor Greg Murray will introduce our next speaker, Dr. Tony Montagna. Lunchtime.